Dr. V.K. Rajoria. I am Head and Chief of Department of Functional and Stereotactic Neurosurgery at NeuraXis DBS Care. Today I will be talking about a procedure called as Deep Brain Stimulation. As the name itself indicates that it has something to do with the deep brain. This operation or this procedure is quite different as compared to the general neurosurgery which we do for tumors, head injury, brain hemorrhage and so other things. In this kind of operation or procedure, we implant a electrode deep into the brain. Before I talk about the surgical aspects, let me tell you that why we do these procedures. We do deep brain stimulation for movement disorders like Parkinson's disease, dystonia, essential tremors, and also for other things like epilepsy, and recently it has been FDA approved for depression and obsessive compulsive neurosis. The most important factor for the good post-operative outcome is the proper selection of the cases. In Parkinson's disease usually we operate when the patient has tremors, rigidity, slowness of the movements in the off period, or in the on period, that is when the patient has taken medication, he develops dyskinesias or excessive abnormal movement. The proper selection of cases and the proper indication is a teamwork of neurologists, neurosurgeons and neuromodulation specialists. This thing will be talked about in detail by our neurology and neuromodulation specialists. I will concentrate on the surgical part of deep brain stimulation. As the name itself implies, we implant the electrode deep in the brain. This deep area of the brain is called as basal ganglia, and we implant the electrode in one of the nuclei of this basal ganglia. For Parkinson's disease, we implant the electrode in STN, subthalamic nucleus. This deep nucleus is of the shape of a small almond and the size is around 6 to 4 millimeter. Now you can think that in such a large brain, one has to implant the electrode in an area whose diameter is only 4 to 6 millimeter. So this needs very precise planning and execution of the procedure. This is the only neurosurgical procedure where the planning needs to be done very diligently. In brief, I will tell you about the surgical steps. The first step is to do a high resolution MRI of the brain. Every millimeter of the brain is scanned. This gives us an idea for the anatomical localization of this structure, which is only about 4 to 6 millimeters in diameter, situated deep in the brain. Once we have defined this structure in a high resolution MRI on our planning station, then we wheel in the patient to operation theatre. We put a frame on the patient's head which is called as a stereotactic frame. This frame is fixed under local anesthesia. Then we do a CT scan. This CT scan is called as stereotactic CT scan. The images of the CT scan and MRI scan both are fused in the planning station, and then we do the anatomical targeting of the structure where we have to put the electrodes. At the same time, we also decide the trajectory of our entry into this deep structure so that we can avoid the important area of the brain. Once we have done this anatomical localization, we open the skull by making a small hole under local anesthesia. We cut the membrane of the brain and we put our electrodes into the brain. To be doubly sure, we do the recording, electrical recording from the cells of the brain. The cells of the brain in different area, they fire in a different way, and so we can pick up the electrical signals from the different areas and we can know that we have reached to the target place. Once we are at the target place, we stimulate that area by the electrical current, and the neurologist and neuromodulation specialists who are present in the operation theatre, they judge what is the response in the patient, and very important, at the same time they also judge that the patient doesn't get any side effects by stimulation of this target. Please remember, we are only talking of the 4 mm area deep situated in whole of the brain. So one has to be very sure. Once we are sure, we implant the electrode at that point. The same procedure is repeated on the other side of the brain. Then we implant the battery or the internal pulse generator below the collarbone inside the skin. The wires are tunneled from the scalp to that pulse generator. After that, the most important part comes, that is the programming of that pulse generator. This programming is done after a few days. It is done by the neurologist and neuromodulation specialist, and I leave up to them to talk on this. But what I can tell you is that the electrical current has 3 components. One is the strength of electrical current, the frequency of electrical current, and pulse width of the electrical current. So these things are then adjusted by neurologists and neuromodulation specialists, and the medications are gradually tapered off. Thank you so much.